Hi, everyone. My name is Catherine. I am a recent Columbia grad and a current MPH student at Columbia studying epidemiology. And I'm going to be talking to you today about my project with the Duke Endocrine team and the Duke Population Health Management Office related to Duke's osteoporosis post-fracture treatment patterns. And as some of you all might be familiar, osteoporosis, which is the weakening of bones due to a loss of bone density, is extremely common in the US, and around 44 million Americans experience it. And this is particularly prevalent in women over the age of 65. Those with osteoporosis have an increased risk of fracturing a bone because of it, and this is known as an osteoporotic fracture. Experiencing a fracture when you're over the age of 65 isn't the same as experiencing one in your 20s because it can be incredibly debilitating due to an extended recovery time or a loss of mobility or independence, all of which can have devastating health and economic consequences. And once an individual experiences an osteoporotic fracture, their risk of experiencing a second fracture goes way up. And the more and more someone fractures, the greater the risks of severe outcomes and even death compound. And this is very concerning to the medical community because osteoporosis is not always caught before the first fracture, making it critical that steps are taken once a fracture happens to prevent another one and avoid the increased chance of these really severe outcomes. So physicians need to act immediately when an osteoporotic fracture occurs to prevent a second one. And to ensure that actions are taken to prevent second fractures, treatment guidelines have been established that physicians are meant to follow after someone experiences an osteoporotic fracture to prevent them from experiencing another one. However, the physicians I worked with this summer believe patients in the DUHS specifically aren't always receiving any of the treatments specified by the guidelines, specifically when it comes to the valuable preventative therapy of anti-fracture medications. And in terms of these medications, the treatment guidelines generally recommend that any patient who experiences an osteoporotic fracture and is eligible health-wise receives an anti-fracture medication within 6 months of their initial fracture date to increase their bone density to attempt to prevent another fracture. There are some nuances in terms of the practice of this guideline, but this is the general recommendation. So we wanted to look into this to see whether everyone who needs this anti-fracture medication is getting it. And if not, do certain factors predict physicians' adherence to treatment guidelines when it comes to medication? So to answer this question, we collected data of all the women over 65 who experienced any fracture in the Duke Health ACO from 2018 through 2021, which is about 3,100 patients. Now, some of the patients in the sample did not experience an osteoporotic fracture, or they had a certain health background that made them ineligible to receive anti-fracture medication at that time. So the data of those patients were eliminated from our sample. And we also didn't have sufficient representation from racial identities other than those who identified as white or Black. So the data of patients who identified in other ways were unfortunately eliminated as well. Ultimately, our sample consisted of around 1,500 patients, and all of these patients received outpatient treatment only for their osteoporosis. This was their first osteoporotic fracture, and any hypothetically of these patients were eligible to receive preventative medication post-fracture. So this is a little bit of background into our goals and data collection process, as you can see in the first column of my poster. So in initially analyzing the sample, we learned that the average participant was about 75 years old, and 89% of our sample identified as white and 11% identified as Black. It's important to note also that this breakdown isn't necessarily representative of the Durham area. There is an overrepresentation of individuals who identified as white in our sample. But we also noticed that as the physicians on our team suspected, only 23% of eligible patients were receiving an anti-fracture medication within 6 months of their fracture date, which is when the treatment guidelines recommend. And obviously, this 23% figure is not ideal. But with the figure, we now have this evidence that those in our sample were not always getting treatment guideline recommended care. And we were curious as to whether certain factors predict the increase or the decrease of the odds of getting the medication. And this is where we conducted a logistic regression analysis. So in this analysis, our dependent variable was whether the patient received an anti-fracture medication within 6 months of their fracture date, as the guidelines recommend. And we had a few independent or predictor variables, and I'd like to talk a moment about our predictors and why we chose them. So the first predictor was patient age, and we included this in the model because maybe medication isn't offered to a patient because of their age. Maybe the side effects outweigh the benefits if a patient's life expectancy is on the shorter end. Rebuilding bone density isn't an instantaneous process, and maybe given the patient's life expectancy, it isn't realistic to prescribe this medication to them. And that could be a reason why a patient is less likely to receive a medication. And the second predictor was racial identity. And we included this to account for some elements of systemic racism or inequalities in access due to bias. Thirdly, we included several variables related to comorbid disease in this model that included diagnoses such as diabetes, stroke, COPD, and congestive heart failure. And although these diagnoses may not have been made around the time the patient fractured, maybe they indicate that the patient is in generally bad health, which could cause dealing with osteoporosis on a preventative level to not be a top priority for some physicians. We also included a variable on whether a patient had a formal osteoporosis diagnosis listed on their problem list on their medical chart that their physicians view. For various reasons, a formal osteoporosis diagnosis isn't automatically listed when a patient has a fracture consistent with osteoporosis. However, maybe having a label on the patient's record immediately after they fracture draws more attention to the need for further investigation of the issue, especially for physicians that have less experience with osteoporosis and anti-fracture therapy. The final independent variable surrounded whether the patient met with an endocrinologist within 6 months of their fracture date. Our thinking was, perhaps given an endocrinologist's specialty in the area of osteoporosis, they are more comfortable prescribing the medication. So maybe consulting with one increases the patient's odds of being prescribed a medication at all. When you put all these predictor variables together, they control for each other. So by including them in one model, we were hoping to have a sense of how all the variables work together to predict the increase or decrease in the odds of getting this important anti-fracture medication. And we ultimately found 3 significant predictors in our regression model. And you can see the information about our results in the center column of this poster. The first is that individuals who had a formal diagnosis of osteoporosis listed on their chart were 9 times as likely as those who didn't have a diagnosis on their chart to receive an anti-fracture medication within 6 months of their fracture. The second is that those who had a consult with an endocrinologist within 6 months of their fracture were 5.5 times as likely as those who didn't have a consult at all or within 6 months to receive a medication in the appropriate time frame. And finally, those who identified as Black were significantly less likely to receive an anti-fracture medication than those who identified as white. And this figure is 0.23 times as likely. To us, these are very illuminating findings, and their implications are absolutely worth exploring further. But there are 3 limitations of this analysis that we did want to note. The first is that we can't establish causality with this model alone. And although our initial structuring of the data ensured that temporality was not an issue by making sure the date a formal osteoporosis diagnosis was made and an endocrine appointment occurred, these dates occurred before the medication was placed, we can't establish true causality with this model alone. We can only point out variables that predict an increase in the odds of being prescribed a medication, but we can't be sure that these variables caused those odds to change. Secondly, we don't have as much racial and ethnic diversity as we would like, especially in terms of representation of the Durham area. Access to medication and care, as you all probably know, is not equitably available to everyone. And with this study, we weren't able to investigate the potential impacts of these disparities as far as we would like. And finally, we didn't have social determinants of health data available to us, so we couldn't control for things like socioeconomic status, which could influence the timeline in which a patient sees a provider or whether receiving a prescription is economically feasible for a patient at all. So we couldn't explore whether the odds of being prescribed a med change once you factor that in. However, with the results and also these limitations in mind, we still think we can use these findings to inform how we approach osteoporotic post-fracture care in the Duke University Health System. And we thought of 3 interesting potential avenues or changes that we hope to explore in the future as a result of this analysis. The first is maybe having an osteoporosis diagnosis formally in a patient's chart automatically after they have a fracture consistent with osteoporosis, and having that diagnosis trigger a message to the patient's primary care provider to investigate the issue further is important in getting physicians to take steps toward fracture prevention and potentially prescribe appropriate medication. Another thing is maybe meeting with an endocrinologist is valuable for ensuring appropriate meds are prescribed. Maybe we need to figure out a way to get more patients in the door in endocrine, or decrease scheduling wait times, or increase the number of endocrinologists on staff so that patients can be seen as soon after their fracture as possible. And finally, it's obvious that racial disparities play a role in the quality of care provided. And this is deeply concerning, and we must take steps to ensure equitable resources and care are offered in the DUHS. In terms of next steps, we want to establish that a causal relationship between the predictors that were significant in our analysis and anti-fracture medication prescription exists at all. And one way to do that is by conducting an intervention analysis. And some DUHS physicians that we spoke to about our findings have indicated that they are interested in taking steps to formally add an osteoporosis diagnosis more aggressively on a patient's chart after someone fractures, and also that they're interested in figuring out a way to improve the referral process and access to appropriate endocrinologists. And if these measures are ultimately implemented, we will want to compare the experiences of patients who received these changes to an appropriate sample of patients who came through the DUHS before these changes are made, to have a better sense of the intervention's impact on the prescription of these valuable medications. So that is a brief overview of my project for the summer. Thank you so much for listening, and please feel free to reach out to me for any additional questions.